Symposium, and we have today 13 presenters who have already submitted. We had invited submissions of challenging cases, and almost 75 people had submitted their videos, and we've been able to select from the evaluators about 13 good representative videos. And we have an esteemed panel of judges who are all highly experienced. And I can already see Dr. Jagatram and Dr. Boris Malukin. I'll request them to please come on stage. And as our other panelists come in, we will invite them as well. We will have, all the presenters have submitted their videos with voiceover. And we will be having 3 awards at the end of this session. One is for the most challenging video, which will be by audience choice. And there will be 2 other awards, which is one would be for the most educational video, and one would be for the best new technique. And those would be by the judge's choice or the panelist's choice. So I'll request you to watch out for these videos to see which ones would qualify for these 3 awards. One by the audience poll would be basically for, we have audience voting pads, but we realize that with a hall of this size, we probably won't need it, so we will do a voice vote. We will read out all the 13 videos at the end, and we'll do a voice vote. I think that would probably help us suffice. So, Dr. Chief, I would request you to please join us on stage. So we have, I'm just waiting for another 2 minutes because it's loading here, and I'm just watching how it loads. It's being transferred from the drive to this. So we'll just take 2 more minutes. We have some very interesting videos. So how it goes is that after each video is shown, we will be inviting the presenter to be on that podium. And as I will be joined by Dr. Ashwin, and he will be here any minute, I think. We will be presenting from that podium, and immediately after that, we will have a small discussion of just 2 questions on each presentation, and we will be going with panelists, who are distinguished in that particular area to help us come out with a take-home message, because each of these videos carries some take-home message, which is, probably what we are looking for, and with that, we will be able to give you some take-home tips, which are. I'll just see that Ashwin is still not here.
We have to evaluate these videos. They decide the best video. We will decide. Audience will decide just like that. Individually we have to.
Come fast. No, it's 4 o'clock. It's 4 o'clock. It's 4 o'clock. I'm going to start it in 1 second. Come fast, yeah. Okay, so I think the presentation is fully loaded now. So we have myself and Ashwin who are going to be anchoring this session, and we have the panelists. Some of them won't be able to come, Dr. Mohan Rajan and a couple of the other judges, Dr. Maipal, they're involved with the election, so they will not be able to make it, but we'll still do well in their absence. And going on to the first video for today. So as I said, and I will repeat for those people who are joining in late, the audience will be doing a poll at the end for the most challenging video, and which gave them the best message. The first presenter for today will be Dr. Aniket Ginodia. If he is here, I would invite him to come on stage. And his video is titled My Faco Century, but I'm stumped, bold, and caught out. So it will play from here, and there is a voiceover. So you just stay there, and then we'll have some questions for you.
Good afternoon, everyone.
Can we have the sound?
Graduating from SSCS to faculty was an arduous task. Inspired by my mentors, I entered into the world of faculty, studying and falling, but picking myself up because there were so many hands to hold. Through this video bouquet, I bear see after capsular staining? Here, I saw the anterior capsule was fibrosed. So, I decided to continue with the Luthra, proceeding slowly with the centripetal pull, but the rexis extends into an Argentinian flag sign. I used a micro scissor to cut the flap and complete the half rexis with the help of micro rexis faucet. And similarly completed the other half. I did a gentle hydrodissection and nucleus management, concentrating on the front axis to observe the flap motility sign. I will place in the back. Was the vitreous in the anterior chamber? I was a little unsure. I used tripod to stain, but thankfully there was no vitreous. Ports hydrated and the case closed. On my 99th photo, I felt elated nearing the century. A case of mature cataract with fibrosed anterior capsule. Sideboards, capsular staining, and visco injection done. I started rexis with cystitone, but the anterior capsule was fibrosed. So, I used the Luthra to complete the rexis. Hydrodissection, nucleus management done. IOL well placed in the bag, but the moment I start to remove the viscoelastics, the IOL dropped into the vitreous. My heart sank. I decided to do hydrovitrectomy, and while doing so, I got a brief glimpse of haptic moving anteriorly. I grasped the haptic of IOL with MacPherson and brought out the sinking IOL. Anterior capsule margin was well visible, so I placed the same PMA IOL in the sulcus after hydrovitrectomy. I sutured the wound and the case closed. And after slipping, dropping, falling, I ultimately trust towards my century in phacoemulsification, and this is what I learned in my first century. My learning tips in phacoemulsification: watch initially every steps of your mentor's surgery. Watch live surgery time and again. Watch at least one surgery on the YouTube every night before dozing off to sleep. Start surgeries with the low parameters first. Get the feel of the machine. Request the applicate expert of the machine to help you in the nucleus management. Do phaco in normal grade 2 to 3 cataract cases first. Never start phaco in very soft and very hard cataract initially. Convert to SICS when in trouble. Call your mentor when in trouble. My gratitude to my patients, my theatre colleagues, and my mentor.
Thank you.
Thank you for the video, Aniket. Thank you.
Thank you, sir.
Dr. Chi, I wanted to ask you on this case, and I think the panel, the audience also would like to know. Would you do a small rexis first and then extend to making a larger, or what would be your scenario, how to handle these intermittent cataracts which are going to go Argentinian flag? Or
the problems are not just the swelling that we saw, in these lenses, but also the fibrosis that Dr. Nikit actually encountered that actually contributed to the tear out.
tear.
So what I do routinely is, at the clinic, I would examine them carefully. to see whether there's any fibrosis there that I might encounter. And actually, I have photos of these eyes so that I know exactly what to avoid and how large the rhexis should be at what stage. But I think pre-op preparation is important. I actually routinely run pre-op mannitol for these patients that are really very, very swollen in order to shrink the lens and also the vitreous. And I usually prefer femto if I'm going to encounter a fibrotic area or large areas of fibrosis, especially those that I cannot avoid if it's going to come within that 5 mm capsulotomy that I'm going to do.
Fantastic. Anything from the audience? One.
Right, sir. Actually, these all are the charity patients. These all are the charity patients I learned. I did it during my fellowship period. So we are getting only PMA lens in my training initially. So these are the initial surgeries which I did. So I placed the PMA lens only. I know, but in our institute we are getting PMA lens. After that, foldable
Sir,
lens.
your question. Or comment. Yeah.
T.
In infusion cataracts, starting off initially can be a two-step capsulorhexis. Make a smaller one first, and once all the intralential pressure is gone, then you can very comfortably go on.
So when we saw this patient on the slit lamp, there was a small portion of fibrous capsule. So I thought that we can just circumnavigate and complete the rhexis. But on the table, the situation was different. And when I started, it met a ginger flag sign, and then I proceed the case with the micro.
Thank you. Thanks, Aniket. In the interest of time, I'm going to move to the next video, and we'll take one panel at a time.
So thank you.
So we'll invite Dr. Amit Mishra to please come over, and he has an interesting video. And for this, we are going to request Dr. Jagatram to have a discussion on this video. So, come Amit.
We present a case of tilted and subluxated SFIOL after fast vitrectomy, resulting in a loss of visual acuity. This is the preoperative picture showing a decentered and tilted IOL because of the loose nasal suture. The option of correcting it is by fixation with a proline or vortex suture, an IOL exchange, or a sutureless fixation. We have gone for a sutureless fixation by modifying the iris hook and utilizing the Yamani fixation technique. It's a little modification which has been done in this case. A dry run is done before the actual case. The hook is threaded into the tip of the needle, and with the IOL, haptic eyelet is being engaged with the iris hook and seeing the strength. The loose haptic is being seen over here. We prefer a past lanine fusion. The needle is inserted 1.5 millimeter away from the limbus in an intrascleral fixation as described by Dr. Yamani. The hook is threaded into the tip of the needle by railroad technique through a paracentesis, and a microforceps is used to grasp the haptic and position it in such a fashion gently so that the hook can be engaged into the eyelet of the haptic, taking care not to force it much. Once it is engaged, the needle is withdrawn gently, grasping the iris hook simultaneously lest it should slip. The hook is cut flushed with the forceps, and the pendant edge is cauterized to make a flange. prefer to suture the infusion port, especially in a pediatric patient after past venoplectomy. Now one can see a well-centered implant. These are the post-operative picture showing a well-centered IOL, and the flange can be easily visible at position. These are the abrasion profile showing reduced abrasions. A luxated and tilted implant needs to be corrected to increase the PCVA. There are different options, and whatever the surgeon is most comfortable should utilize. We have taken iris hook to utilize a sutureless fixation in this case, resulting in improved vision of the patient. We have found this technique to be quick, effective, safe, and with minimum manipulations.
So that was something new. And Dr. Jagatram, would you like to ask Amit anything about this technique?
I think this was very nicely done, and because this is something new, that haptic was taken from the hole, it was hooked, and haptic was taken out and inserted. But there is another way also doing it, that outside you make a incision, scleral incision, and a small tunnel, and put that haptic into that. Into tunnel, as we do for sutureless surgery.
Right, sir.
That is the other way. But otherwise,
So would you
this
be,
appears to be
would you be
nice
scared?
stabilization of IOL.
Yes, sir. So would you be scared that the iris hook can get disengaged in the future because it's only anchored into the eyelet of the haptic? That's one thought. And the other was that this is only possible with some IOL which has an eyelet. Otherwise, obviously, you cannot.
I think technically, initially for beginner, it may be a bit difficult, but once it is mastered, it can be done.
He has done it very elegantly, but I don't know how reproducible that might be in average
Yeah, that
surgeon's
is
hand.
much more important.
Right.
Reproducibility is
And
much more
maybe
important.
we have Dr. Imane himself here. Would you like to chip in with something for this technique? Did you ever try something like this, or or
I have
something
no
new for you?
experience of like this, but I forgot the name. But the Brazilian doctor developed a double flange technique. So, and I don't know the hook is strong enough to hold in the future. So, I will make two flange for inside and outside of the eye. That is
What
stronger.
is, can I ask, what is the memory of proline?
Yeah, that's
Because I think proline memory, the memory of proline is not that great, and it might give way over time. Yeah.
so. I think we'll go on. Sorry.
This is PMMA hook.
No. This was iris hook, which is a proline.
Yeah, this is the PMMA
It's a
lens.
proline. Yes.
But the
Yeah,
hook
this
is
is the PMMA.
proline.
PMMA cannot be, flange cannot
The
be
hook
made. I
is
doubt it
proline,
can be made like
so
that.
it give way
It has to be
sometime.
proline.
Because the
right?
memory.
Thanks, Amit, and we'll go on to the next one.
He's talking about
So-
Canabrava.
Dr. Amar Pujari, can we have
He's asking, he's
please
talking
here?
about the Canabrava technique.
Is
The
he here?
flange double.
It's not here. He was actually in a course. I think he'll join us later, so we'll go on to the next one. Yeah.
So Ashish?
Yes.
I'm going to show a case scenario where we have successfully managed posterior capsular. Here we present a real life situation where one of our surgeons, while trying to remove cortex with a phaco probe, ended up with a capsular red. As I noticed the red, I asked the surgeon to just stop, remove the phaco probe, and put a visco-dispersive viscoelastic into the anterior chin. As I was getting ready to manage this situation, Once I was sure that there is no vitreous in the AC, I injected the intraocular lens in the back. Wow, we could complete the surgery in a short time. Now let us analyze the fluid dynamics that we use to manage this red. This animation shows our option 1, that is the dry aspiration with Simcoe's cannula. As we do dry aspiration, the cortex is aspirated, there is no inflow. This creates a vacuum and negative pressure, leading to anterior chamber collapse. The cornea dips down, the posterior capsule comes up, and the vitreous rushes into the anterior chamber. Once the vitreous is mixed with the cortex, the story is totally different. The grave is dark. If we analyze our second option, that is the coaxial cannula, we need to remember that irrigation port is close to the aspiration port. And if we analyze the fluid wave, it strikes with a force perpendicular to aspiration. In a coaxial cannula, once we are inside the anterior chamber, at the time of removal of cortex, the fluid wave strikes with force at the posterior capsule and into the vitreous cavity, leading to vitreous prolapse. This is more so when we tilt the cannula to remove the cortex and the fluid wave directly goes into the vitreous cavity. And yes, if the fluid goes into the vitreous cavity with a force, then the vitreous is certain to come out. When vitreous is mixed with cortex, we have to do nothing but a vitrectomy. Now, finally, what we did. Before we start to show what we did, let's look at the fluid generated by the bimanual irrigation and aspiration cannula. The fluid here is parallel to the corneal surface and the posterior capsule. This animation shows that the viscodispersive material first coats the red, then the irrigation cannula is kept near the corneal port. The fluid waves generated by this irrigation cannula does not disturb the red, and the aspiration can be done gently. The anterior chamber is maintained at all times. There is no turbulence, as the vacuum created by aspiration is replaced by the fluid coming from the irrigation port. There is no fluid wave that is directed to the posterior capsule or the vitreous cavity. So friends, we need to remember that in the anterior chamber, the irrigation port is on the top, near the corneal surface, and the rent is down. So we need to keep the fundamental principles of using a viscodispersive material, the fluidics of bimanual aspiration cannula. Thank you. This is a LAL 2020 eye care presentation.
Thank you, Ashish. Someone who's won awards based on PCR is Dr. Rohit Om Prakash, and I think it's good to have someone like him on panel. Why don't you give us your little bit of insight as to what you would do differently, whether you've had complications even after the cortex is all removed, maybe during implantation, have you had any issues?
I think it was a perfectly managed situation. All that would I have done differently would have been that instead of using bimanual, because with the bimanual, no doubt the irrigation is on. First of all, triamcinolone role should have been totally taken into consideration. Second, I would have used the gills if I have to do a dry aspiration. I would have used the gills Welsh technique, wherein after filling the chamber fully as you did, because when you use the gills technique, you are not the vacuum is not much and the chamber doesn't collapse. And last but not the least, checking like this is what Steve Charles would never have advocated, because that gives traction to the retina behind. So that should have been avoided. Triamcinolone could have been used.
Yeah, that's a very valid point. But what I was checking was from the outside to the port to the rent, so that if there is a vitreous wick, it will go inside the thing rather than pulling it. And the second thing is that we have not used we've used the bimanual cannula. We've not used the dry aspiration in this case.
Yeah, the bimanual with the irrigation on still, there's some bit of, and you could have kept the irrigation port farthest away from that point, because that could have also. Anything more else?
Dr. Boris, procedures would you recommend in such cases to
I think this case was quite nicely managed, and I think it was a good point that you need to keep the anterior chamber always inflated, which is a key issue. The other thing in this case is I always look for the sharp edge, because when you have a rent in the posterior capsule, you actually, in many cases, you can see the sharp edge. And when you start manipulating, so the tear extends from that to the periphery. So I was trying to find this sharp edge and convert this into the posterior capsulorhexis. And with posterior capsulorhexis, there is no way this capsule rent will extend. So I think in that case, there was probably no such a sharp edge that can extend to the periphery, but I think in 99% of cases, at least in my cases, it exists. So you need to carefully look at that.
Thank you.
Thank you.
Thank you, Ashish.
Thanks, Ashish. We'll have Dr. Amar Pujari. He's joined us now, and he has a nice presentation which delineates which decodes how hydrodelineation works. So here goes.
Decoding the mechanism of hydrodelineation in tricky posterior polar cataracts using intraoperative microscope integrated OCT by Dr. Amar Pujari and co-authors from Dr. R.P. Center for Ophthalmic Sciences. Our first case is a 44 years old female with posterior polar cataract. Here, we demonstrate the hydrodelineation with real-time intraoperative OCT. The first wave of hydrodelineation produces a golden ring and successfully separates the nucleus and the epinuclear plate. Another attempt of hydrodelineation is made just peripheral to the first golden ring, but well away from the equator. This second wave of fluid is seen to pass closer to the posterior capsule. In the replay, we can see that this second wave creates a fluid pocket at the posterior pole, thus endangering the posterior capsule. But thankfully, the posterior capsule remains intact. Our second case is another posterior polar cataract. The OCT image demonstrates the epinuclear cortical junction and the posterior polar cataract. Here, a single attempt of hydrodelineation is successful and the posterior capsule remains intact. In our third case, we demonstrate hydrodissection in a posterior subcapsular cataract. We insert the cannula just underneath the capsulorhexis margin and go close to the equator to inject balanced salt solution. The hydrodissection is successful. In the replay, we can see that the hydrodissection begins at the posterior pole of the lens. The maximum distension is produced at the posterior pole, and then the dissection proceeds from center to the periphery of the lens. Further injection distends the capsular bag and pushes the lens matter upwards. In our fourth posterior polar cataract, we can see that the hydrodelineation is successful, but it has caused a break in the posterior capsular plaque. Some fluid can be seen behind the plaque, but the posterior capsule remains intact. In our fifth case, while attempting to perform hydrodelineation, some hydrodissection takes place. This can be be seen clearly as a pocket of fluid between the cortex and the posterior capsule. After successful phacoemulsification of the nucleus, we can see that the posterior capsule is intact. First creates the maximum tension at the posterior pole and thus is contraindicated in posterior polar cataracts. In these posterior polar cataracts, even the routinely performed hydrodelineation may produce tension at the posterior capsule just beneath the plaque. Thus, in these cases, even hydrodelineation should be performed with caution.
So, nice video, and I wanted to ask you, like, based on what you kind of gleaned from this study. Now, everybody will not be able to afford a intraoperative OCT, and but what would you recommend based on this, that if for your hydrodissection, like in which cases clinically would you prevent this kind of a blowout from happening, and where to suspect? Is there something else we can do? Can we use a UBM? Can we do something else? Because OCT helps you understand how it happened, but
yes, sir.
Any conclusions?
We have a total series of 120 cases of postopolar cataracts, sir. So one thing we describe as a conical sign in preoperatively how to see the posterocapsular deficiency, that is under review in JCRS, sir. We have another 100 cases on CASIA 2 OCT, which is like similar to UVM, which is able to delineate the posterocapsule. Again, we are going to describe 3 signs of posterocapsular deficiency, sir. At the same time, we did 12 cases of IOCT guided hydrodelineation, sir. Hydrodissection is generally contraindicated, and we saw what is going to happen to the how the nuclear suppression is happening between the nucleus and the epinucleus, and what is that like how the capsule and the plaque is going to behave during hydrodelineation. We don't know, sir. So we wanted to see using real time. So in some cases, we saw that even simple hydrodilation can cause inadvertent hydrodissection. So you should be judicious. If you are not able to see the golden ring, probably fluid has gone behind the plaque. That is one thing, sir. Second thing is, you can see in the 4th case there was a fracture of the plaque or the posterior cortical opacity. So that can happen. If you are seeing that one, again you should be judicious. There might be opening of the capsule. General ophthalmologists may not be aware, but here you can see, sir.
Dr. Milind, would you like to comment on this, whether this is actually going to be useful in kind of translating into some benefit for us?
So the key problem to define, let's think of it that way, is there a way of predicting which capsules will create problems for you before you start surgery? So that's the first question to ask yourself. And the question then comes, okay, would a preoperative OCT or anything like that help us in identifying those patients where we have problems?
Yes.
Now, it's beautiful video. It's a great way of understanding what's going on. But in terms of the surgical strategy, what are you recommending? That we don't do hydrodissection, we don't do hydrodelineation?
We routinely don't do hydrodissection, sir, but hydrodelineation should be judicious. That is our recommendation.
So what do you mean by judicious? It means you shouldn't break the posterior capsule.
No, sir. If you are able to do, if you are able to see the golden ring, probably a proper hydrodelineation has happened, so you can take out the nucleus.
So if you get a golden ring, would it allow you to predict that patient where the capsule, the hydrodelineation leaked into the hydrodissection space?
So we didn't see in 12 cases, sir. That can happen. We are extending this observation. We have submitted 12 case series to JCRS as original article.
The question is, will it allow you, if you see a golden ring, are you happy that the posterior capsule is not ruptured?
In our 12 cases, we didn't see any rupture, sir.
In the other cases, in our cases? Sorry, I'm not being difficult. I'm just trying to question the whole thing.
We are going to extend the study for deficient posterior capsule, or we are going to observe it further. So if there is any sign for in future.
It's a great video, and I think it's important to understand all the mechanisms of this. So congratulations.
Thanks.
Thanks.
Thank you, Ken. Thank you. Deepak, can we have you? Yes. While we play your video.
Hi, this is Dr. Deepak Mekul. Let me take you on a ride of a very interesting case of a traumatic cataract in a 50-year-old man. At the time of presentation, he had sustained a blunt trauma about 3 years back and was not seeing in that eye since then. Let me take you through what was going inside my head. The cataract's lens looks displaced. Is it subluxating? Well, there's no evidence of phacogenesis. Then maybe the lens matter could have been partially absorbed, giving the pseudo-subluxated look, right? What is the status of anticapsule and the posterior capsule? Can't tell presently. Is there any vitreous disturbance? Again, not sure about that. Well, the B scan is normal, but there's something interesting in the A scan biometry. An unusually deep antechamber. If there is no subluxation, then this could possibly indicate the presence of a pre-existing posterior capsule defect. My goal would be to preserve the antecapsule and the posterior capsule if possible, which would ensure that I can place a posterior chamber lens either into the bag or in the sulcus. And in the worst case scenario, I would have to go with an iris flaw lens. Now let's see how things turn out. After creating the side port, I am staining the antecapsule with very little amount of trypan blue, hoping that it does not go posteriorly and obscure the red glow subsequently. I decided to make the 0.8mm squirrel tunnel instead of my regular clear corneal incision. During handling that capsule,
I'm sorry. I have loaded it, this thing. If you want. 1 minute, let's see. I'll just give it a second shot. Huh?
Hi, this is Dr. The anticapsule turn out. After creating the side port, I am staining the anticapsule with very little amount of trypan blue, hoping that it does not go posteriorly and obscure the red glow subsequently. I decided to make a 2.8mm scleral tunnel instead of my regular clear corneal incision. During handling the anticapsule, I will get information about the status of zonules. As a puncture, well, I don't see any wrinkling that suggests the zonules could be quite alright. And also, as I start tearing, the anticapsule tears quite easy. My goal is to achieve a 5mm excess, and I think this is good enough. So far, so good. Now, since I'm not sure about the status of the posterior capsule, I don't do hydrodissection. I'm just trying to nudge the nucleus around and try to figure out whether the PC is intact. I'm injecting OVD behind the nucleus and also to nudge it to the side so that I can have a view of a possible PC tear. And in just a couple of seconds, I could find what I anticipated. This thin line is most likely the edge of a torn posterior capsule. So my strategy now would be to mobilize the nucleus out of the bag and try to emulsify it in the antechamber and then place a multi-piece intraocular lens into the sulcus. Using 2 Sinskey hooks, I mobilize the nucleus into the antechamber and push OVD both in front and behind the nucleus with the endothelium. At this point, I am certain that there is no vitreous prolapse. I begin emulsifying the nucleus, and after phagoing some part of it, I decide to use the IOL scaffold technique popularized by Dr. Gaurav. This would help preventing any lens matter dropping down into the vitreous cavity. Again, under the cover of dispersive OVD, the nucleus is gently manipulated towards my right side of the antechamber. So now, with a clear view, I proceed to implant the lens, and then the multi-piece lens is gently manipulated into the sulcus. Now, before emulsifying the nucleus, I want to confirm the absence of any vitreous in the antechamber by using triamcinolone, and once it is confirmed, I proceed to emulsify the nucleus as slow as and as gentle as possible. Now is my time to remove the OVD both in front and behind the lens. At this moment, I become suspicious of some vitreous prolapse. Again, I want to confirm it by using diluted triamcinolone acetate. At this point, I'm not sure about any vitreous prolapse. I still decide to proceed with antivitrectomy since I needed to remove the OVD which had gone behind the posterior chamber into the vitreous cavity. In a couple of minutes, limited antivitrectomy is completed, and now is the time to fix the lens in the rhexis. I ensure that both the haptics are over the anticapsule, and with the irrigation running through the cannula, I use a lens dialer to gently nudge the optic posteriorly to achieve the optic capture. It is done on either side so that the entire optic moves back behind the rhexis margin. The ovalization of the rhexis confirms a perfect optic capture. I'm injecting triamcinolone acetate one last time to rule out any residual vitreous prolapse. The hydration of the ports is done. Eventually the patient did quite well. He was indeed very happy with the post-operative visual outcome in this traumatic eye.
Thank you, Deepak. That was a brilliant video and wonderfully handled case. But Dr. Shin, would you attempt to do something different, especially in a diseased bag like that, or would you do the same, or what would your recommendation?
Yeah, this video is so nice, beautiful, and maybe I do the same, use the same technique. If I can, I will divide the nucleus using 2 hooks, if I can, before using a phaco. But if not, I do the same.
Which 2 hooks, if I may ask?
Fake chopper.
Okay, just choppers. Fantastic. Anybody else on the panel? Anybody wants to comment on?
So, beautiful surgery. Congratulations. I think it's a great way of doing it. The only suggestion I would have is perhaps before you actually try to bring the nucleus out of the bag to check whether the posterior capsule is intact or not, I would assume it's not intact perhaps, and to cover that I might just put some dispersive viscoelastic around to try and cover that, and then go ahead and try and phaco it within the bag. Because the key question then comes, did the capsule, was it ruptured initially, or did it rupture in your attempts to manipulate that nucleus?
No, sir, it was pre-existing,
Sure.
and we, the idea of just trying to nudge the nucleus a little bit aside to just identify the rent. I could
No,
see
the question, does it
rent-
matter if you identify the rent at that stage, or is it better you cover for it and then take the nucleus out?
Yes.
As you would normally do, because the whole nucleus came out pretty, it's in one piece, it's like a chalky, consistent approach. That's just it's a thought, you know. Cases like these, you can never extrapolate from one to the next.
I would not have, I would have put the IOL at the first go rather than...
Yeah. I thought the nucleus was too soft, I could manage it well enough, so maybe that's the only thing.
I've seen traumatic cataracts where the capsule has been ruptured at the time of trauma. And typically what we would see is, if you did a UBM, you'd see lens opacity in the anterior vitreous.
Yes.
So I'm surprised that if this was a pre-existing rupture following trauma, that when you lifted up the nucleus, the vitreous was very clear. And in fact, when I first saw this, straight away I said to Jagat here, this is a Morgagnian cataract, where the cortex is already liquefied and has been absorbed. And even these cases, we can see some of the lens material leach into the back of the eye through an intact capsule.
Yes,
Yeah, but I've done, in fact, a case of live surgery where I did a Morgagnian cataract. And when I phacoed that nucleus and I picked it up, actually it behaved like a posterior polar cataract because it was adherent, because of the long-standing nature of that cataract that was hypermature, and because of the inflammation that's ongoing. It actually gets adherent. And so what could have happened was that when you visco-dissected this nucleus, it was adherent, and basically it's like visco-dissecting a posterior polar, and you can rip it. Because the anterior vitreous was too clear to represent a previous rupture.
There was some amount of white matter, I think you just missed there. In one of the next when I'm trying to manipulate, and there was some amount of lens matter there.
Yeah, so sometimes you can get that even with a hypermature cataract,
ma'am.
where it leaks backwards.
Yeah, it takes better. We seek off. Thank you.
Thanks. So we'll quickly go on to the next presentation. I'll request Dr. Manish Mahindra. He will be showing us some new techniques of iridodialysis repair.
This video will demonstrate iridodialysis repair technique. This is a hand bag technique. As you can see, there is a large iridodialysis. I'm using iris hooks to retract the tissue so as to get a wider view. Rhexis was performed using a cystitome. This was followed by use of absolute tension ring so as to stabilize the back as there was a mild zonal dialysis. Phaco aspiration was performed to remove the cataract, followed by irrigation and aspiration, and then implantation of intraocular lens in the back. Peritomy is performed and scleral tunnel made 2 millimeters from the limbus parallel to the damaged iris tissue portion. Nyloconic suture is passed through the peripheral iris tissue and the needle is externalized. Similarly, the other end of the double arm needle is passed through the peripheral iris and also externalized. Both the needles are then pulled. Nylon suture is again passed through the peripheral iris and externalized. Both double arm sutures are pulled and tied, and the knots are buried in the scleral tunnel. The damaged iris tissue is thus repaired. This is day 1 post-op and this is day 7 post-op. Another interesting technique to repair areodalysis is modified sewing machine technique. In this case of traumatic mature areodalysis, cataract is removed followed by dialysis repair. Scleral tunnel is made 2 millimeters from the limbus parallel to the damaged iris tissue portion. Nylocronin suture is dogged and passed through the 26 gauge needle and then pulled from the opposite side, leaving a small tab of the suture in front of the needle tip. The 26 gauge needle with the proline suture is passed through the peripheral iris and externalized through the scleral tunnel. Suture is pulled out through the needle and held on. The needle is then gently withdrawn and the second line in the peripheral tissue is taken adjacent to the first one in the similar fashion and suture is pulled to form the loop. Once 3 loops are formed, the suture is gently withdrawn from the 26 gauge needle It is then passed through the loops. The ends are then tied and the knot buried in the scleral tunnel. Thus the pupil gets round and the areodalysis gets repaired. This is followed by implantation of the lens and the conjunctiva is covered and cauterized. This is the post-op day 1. Thank you for watching the video. This video will demonstrate areodalysis.
So, Dr. Amar wanted me to pause it. Okay, wait 1 minute. For some reason, it doesn't pause there. Let's take it here. You want me to pause it here? Okay. We wanted to request Dr. Amar to comment on this and how we could, whether we could do it any way better or like he liked the video.
I think Manish, you've done a great job, and Manish is an excellent surgeon. one small thing, if you notice now, you have done either swing machine or you do any iodolisis hang back technique, which you are doing. Now the point I'm making here is, look at that pupil. When you pull the iris like this, there will be a dilatation effect. So what you need to do is a twofold technique. Now with this, once you have done this, fantastic. Now do a single pass fourth row pupiloplasty. And we published this in the JCRS. You understand my point? So if you do now a fourth row pupiloplasty, that dilatation effect which is there on this side will get neutralized. Yes. So this is what we called as the twofold technique, where you're combining hang back and the single pass fourth row pupiloplasty. You can do it with sewing machine and single pass. But if you see in that picture, if you see on the top, wherever the iodolisis is there, obviously you're pulling it on one side. So if you do that fourth row pupiloplasty, that pupil comes back to normal. Otherwise, I think it's a great thing. Small tip, you're playing this game with viscoelastic. Yes. Basically, yes. If you play this game with fluid using a trocar AC maintainer, every time you don't have to keep on injecting, and the fluid will automatically push off the blood, the hyphema which occurs or things like that. Life will become very comfortable. Otherwise, a great surgery.
Another question, Dr. Amar, we noticed that almost all his steps, the needle was going inside out, do you think, because then coming out at the exact point where you've made that tunnel may not always happen when it's a blind technique. Do you think there was a way to kind of, in the hang back technique, probably not possible, but at least in the other
It's a very good point. I'll tell you, even in hang back, one of the problems, understand what he's doing in hang back, you're taking a double arm needle, passing it from the same corneal incision. Invariably, I tell you, many times what happens, you pass it in, you think you're in the incision, it goes through the cornea. Now when you're pulling, it's stuck to the cornea. Or a headache, again you have to cut, and again. Simple trick. Take a trocar AC maintainer, pass it into the eye. But don't pass the fluid. Now pass the needle through the trocar. You understand, the trocar itself becomes an opening for you. That way you will never get that lock into the system there, and they'll make your life very easy. Okay? Right. What he's suggesting is another simple trick is, when you're bringing in the hang back, it doesn't come out through the scleral groove. So if you take another needle from the scleral groove, this side, and lock the two, railroad the two, then you'll come out exactly in the scleral groove exact area.
Yeah, that's a good point, sir, yes.
So thanks, Dr. Manish, and we'll now go on to the next one, Ashwin, and we have this, I'm just pushing it on, So we have Dr. Neeraj Agarwal, who will be speaking on iris fixation of subluxated IL back complex. Ashwin.
Posterior chamber intraocular lens subluxation or dislocation is uncommon but represents one of the most serious complications which needs surgical intervention. This video demonstrates two case scenarios of iris fixation of subluxated IOL back complex due to different etiology, which were managed effectively to restore the pseudophakic vision. The first patient was a 71-year-old gentleman who had a history of successful phacoemulsification and intraocular lens implantation a decade ago, presented with mobile IOL back complex in sulcus. A superior 6 mm sclerocorneal tunnel was created. Paracentesis was made at 3 o'clock position. The wound was entered with 2.8 mm keratome and was extended. Anterior chamber was filled with viscoelastic. The subluxated IOL back complex was extracted with the help of lens holding forceps and spatula, taking care not to disturb the anterior hyaloid face. The spatula was swiped to check for any prolapse of vitreous. Pilocarpine was injected and the pupil was constricted with the help of gentle strokes on the iris. A tenoproline suture in a long curved needle was passed through the cornea and full thickness iris and was brought out again through the cornea, ensuring that the iris bite is around 1.5 to 2 millimeters long. The same suture needle was rotated and used to take the corresponding bite 180 degrees away. A second paracentesis was made at 9 o'clock. A Coughlin hook was used to retract the proline suture below the iris, which was externalized through the main tunnel using McPherson forceps. The other suture was brought out in a similar fashion and kept on the corresponding sides. The right suture was looped thrice around the leading haptic of the IOL. The leading haptic of the IOL was slipped behind the iris. The external suture was gently pulled such that the suture around the haptic got taut and does not slip from the haptic. The other suture was looped similarly around the trailing haptic and rest of the IOL dialed into the sulcus. Both the suture ends were lifted to check for IOL tilt, thus ensuring that the suture is below the haptic. The suture between the cornea and iris was retracted out through the corresponding paracentesis using Coughlin hook and McPherson forceps. Both suture ends were tied together such that the knot lies over the iris. Around 5 to 6 knots were placed to secure the haptic firmly to the posterior iris. The other suture end was similarly secured. The viscoelastic was gently aspirated and the negativa was opposed with cautery. This was a 65-year-old gentleman with traumatic subluxation of IOL back complex in anterior chamber with vitreous prolapse. A paracentesis was made. Viscoelastic was injected in the anterior chamber. The leading haptic of the IOL back complex was slipped behind the iris. An attenuproline suture in a long curved needle was passed through the full thickness cornea and iris, ensuring that the needle is passed behind the haptic and was brought out through the cornea. The trailing haptic of the IOL back complex was similarly slipped behind the iris and similar bite was taken, ensuring that the needle was passed behind the haptic. Anterior vitrectomy was done to take care of vitreous prolapse. Both the sutures between the cornea and iris were brought out through the corresponding paracentesis and both suture ends were tied together. The remaining viscoelastic was aspirated and the anterior chamber was formed with saline. With patience and perseverance, such challenging surgical situations can be overcome successfully.
Thank you, Neeraj, for this video. Dr. Boris, would you plan to do the same thing, or would you do something different? What's your comment on this video?
So talking about the first case, frankly speaking, in this case, I will probably not be removing that lens. I will try to suture it through the bag and through the haptic, and I do believe it works well. Of course, there was no CTR. However, I still believe that the haptic configuration will allow you to securely fixate it to the sclera. As for the technique itself, I think it was quite elegant because for iris suturing of three-piece lenses, we're always struggling with pupil distortion postoperatively. So this is a nice way to avoid that kind of problem. And I really looking forward to try your technique, and maybe I would love it as it seems simple and quite easy to do. So it's congratulations with that.
Sir, just one question. You told the first case you will fix the same back complex.
Yep.
But the lens was the single piece lens. Would it is advisable to fix
It's not. It's not a problem because the lens is sequestered inside the bag. So there will be no contact in between the lens and the posterior surface of the iris. It will be no rubbing because of that. So it will be a contact in between the capsule and the posterior iris, and the sharp edges will be not in contact with the iris. So that's not a problem.
I think two small comment. One is regarding vitreous. We have to ensure that it should be free from vitreous. I think triamcinolone may be used. Yeah. Another is that short-term results are excellent, but what is the long-term result of
Sir,
that
I have
technique?
followed this patient, I think, last 6 years. The patient is doing fine, and patient doesn't have any glaucoma till now. This is what one thing, and the suture, his lens is quite stable and well centered.
Thank you, Neeraj.
Thanks.
Thank you.
And a posteriorly dislocated IOL was noticed. 25 gauge pars plana vitrectomy was planned out. After carrying out the vitrectomy, the IOL was brought out anteriorly. But now we face the challenge of how to bring the IOL in the anterior chamber without compromising the bag. And therefore, the IOL was brought out into the anterior chamber through the area of inferior zonular dialysis. Dialing was carried out. A capsular tension ring is inserted to stabilize the bag. We can also notice that the lens orientation is upside down, and therefore it is flipped back into the correct orientation and dialed in the back. A final adjustment is made, and as can be seen, at the end of the surgery, the IOL is central.
So, nicely managed. Dr. Chi, would you like to comment on this? You love doing these acrobatics inside the eye, and this was unique, yes.
I think this was fun to do. It was pretty innovative that you put it back up to the front of the eye through your zonular dehiscence, which I've never seen done before. And as usual, when we pick them up, they're always upside down. I don't know why. And it was nicely flipped around again. And I was just wondering whether that, you had 4 to 5 clock hours of zonular dehiscence, whether you thought it might be necessary to just anchor that to the sclera through a tension segment or
The
something.
bag was quite stable, and the dialysis was from 3 o'clock to 6 o'clock, so about 90 degrees of the dialysis. So CTR ring fixed it quite well, actually.
What's peculiar is why did it go behind in the first place? Like if it was in the bag, how it managed to come out of the bag and
how did it go behind the intact? So let me get this straight. Capsular bag is intact, correct? So how did the lens end up on the retina?
Probably at the
In
time of
sulcus.
surgery, the surgeon has missed the dialysis part. So maybe they have implanted the lens into the sulcus.
And
So the
slipped
take-home message is when you do the surgery, you must identify the dialysis and try to use the CTR ring. Never put the single-piece hydrophilic lens into the sulcus because it can go through the zonule. So use a 3-piece lens instead if you don't have the expertise of that. And use a CTR ring and try to put into the bag, not in the dialysis, especially into the inferior location of the dialysis.
So whenever the capsule is compromised, as in this in terms of the zonule
Probably at the time of surgery,
you
most
have a
likely.
CTR
It was a
put in.
referred-
Would you prefer a hydrophobic acrylic lens rather than a
If you're
hydrophilic
using
lens?
a CTR ring, hydrophobic single-piece lens you can use. or
No,
a
no, what I
3-piece
meant
lens.
was, would you have taken this lens out and put a hydrophobic acrylic lens in this bag?
To remove this and then again. See, why to disturb the anatomy? If you can manage with the same, we are putting into the bag. We are least disturbing the all anatomy of the system.
Because
The
the
idea is to
hydrophilic
have
lens
the least
will not
distortion of the
resist
anatomy.
capsular contraction the same way as a hydrophobic acrylic
They do
lens
as
does.
well. You can do the capsulotomy later on.
Boris wants to say anything?
You know, it's a tough case because we were not seeing the bag clearly during the procedure, and that I had the perception that the bag was not intact.
Intact, yeah.
my feeling was that it was taken, the lens was taking out through the but of course what we see on the video sometimes does not match what you see under the microscope, so that might be the case. My concern, if that was zonular dialysis, so it should be a massive zonular dialysis for the lens to go through. So
it
it's
wasn't
a
that
6
big
millimeter
enough, yeah. It
optic
wasn't that
lens.
big.
So my question is whether regular CTR is enough to support this zonular apparatus, because in that case I will probably consider using either the segment or modified CTR, because I really think that it's not enough for the regular CTR to support that bag in case of such a massive dialysis.
So, but in this case, the challenge was to basically to manage to take it out and then plan your surgery accordingly. So, if it is a PCR, it's much easier to take out through the PCR and you can plan your surgery accordingly that way. So, but in this case, because the entire PC was intact, the bag was there. So we thought to use the bag in the surgery.
Thank you. Thank you, Dr. Appi.
Thank you.
Please. Can we have Dr. Sohail?
You want to ask
Yeah, why not use 2 CTR instead of 1?
Because they will do the same thing. Yeah.
No, it will give you more protection.
Yeah, because if you see at the end of the surgery, the bag and everything is quite stable, and we have, we dab it and we check whether it is absolutely stable or not. And the lens is well centered, the lens is not getting upside down.
Okay. We're going to have Dr. Sohail talk about his case now.
Okay. For a phaco surgeon, dealing with hard cataracts is still an uphill task and is fraught with complications like wound burn, endothelial damage and PCR. Hence, phaco surgeons are shifting from the classical 4-quadrant cracking method to direct chopping techniques. Of late, FLACS, that is the femtolaser assisted cataract surgery, being an extremely expensive option. Therefore, pre-chopping the endonucleus is still a cheap and viable option for us to reduce the collateral damaging potentials of phaco energy. We in this video presents a newly designed pre-chopper well suited for all grades of cataract, especially the harder ones. Pre-chopper goes through 2.8 millimeter incision, and the left hand uses a Chang chopper to hook the equator of the endonucleus in all these videos. This is a second video demonstrating the intumescent cataract, wherein the surgeon is aspirating a liquid cortex with the help of 26 number needle, capsulorex is being completed, and pre-chopping being attempted. The entire endonucleus now is divided into 2 endonuclei, heminuclei I mean to say, and after rotation again the pre-chopper is dividing a heminuclei into 2 fragments. Phacoemulsification is now being carried to empty the capsular bag of the nuclear fragment. In this third video, we are demonstrating a dense nuclear cataract being pre-chopped with the help of this new pre-chopper. The endonucleus being hooked, the pre-chopper is dividing the endonucleus into 2 halves. This is a viscoelastic dependent technique, and what you need to appreciate is that the fragments which are produced are almost imitating the fragments which are produced by femtolaser. They are very steep, they have a very steep borders. This pre-chopper is also very helpful for dealing with a soft cataract, which at times can produce a cheese wiring when you are using a high vacuum and phaco energy. This elegant pre-chopper is therefore well suited for all varieties of hard as well as soft cataract. Being sleek, the anterior chamber is well maintained, and this is compatible with 2.2 and 2.8 millimeter incision. It doesn't resemble any cross-section forceps like a classical Akahoshi pre-chop forceps. The learning curve is not very steep and is definitely very easy to master. This is the last video of this video presentation where the capsular excess was lost because of the high intralenticular pressure in a intumescent cataract. The end result was a disastrous Argentinian flag sign, and to proceed or not is always in the back of a mind, because we don't want to confront a catastrophe like a nucleus drop during phacoemulsification when the capsular excess is lost. These capsular flaps, irregularly torn flaps, are converted into what we can call it as a pseudo capsular excess, and because the pre-chopper is dividing the nucleus, the other pole of the nucleus being hooked by the Chang chopper, the energy is against each other, and therefore this becomes a very safe option for the phacosurgeon to divide the nucleus. So even in loose zonules and where the capsular integrity is not 100%, we can do a phenomenal nice pre-chop. Thank you very much.
Thank you very much.
So Sohail, first thing, I think there are two questions. One is from the audience and a lot of questions from the panel. The audience wants to know, where did you make this and who's making it, where do we buy it from? Panel wants to ask a few questions on some of the safety options, probably
As
how
far as
sharp
the
it is and stuff.
audience question is concerned, it's not available commercially. It is. It has evolved through almost 1.5 years of research and modifications. Yeah.
I think it was an excellent innovative chopper. I have seen till date. This is excellent, and it is very cost effective, whatever. I think it will be ultimately cost
Manual
effective.
femto.
And we should not undermine the innovations and the skill of the surgeon.
Absolutely.
I appreciate him highly.
Thank you very much, sir. Thank you.
I think Dr. Sohail, you need to be congratulated for that.
Thank you, sir.
Number one, and I think with the incision size, that needs to be titrated because because the chamber would become unstable. So that needs to be worked on. And
Actually, I have used a very hydroxypropyl methyl cellulose rather than using anything like a Hilon GV or a Viscoat. So I have used.
It has to be calibrated.
So that could have, I would say, made my life a little more easier.
Yeah.
But
and
definitely.
with the Argentinian flag sign, with the chamber not being stable with the manipulations, that would have jeopardized the capsular tear to a wraparound tear. So
Definitely. I am not recommending this as a technique, but because I have tried and I had a little bit of a confidence that I should try, I have ended up producing 10 Argentinian flag sign, and I have not succumbed to a complication like a nucleus drop and something. I am not recommending this to a general audience, or even I may be a little scared to attempt a furthermore, but nonetheless I have found this maneuver because the nucleus is wedged against these two forces, and therefore the liability that your tear may further extending and producing a PCR and a nucleus drop is.
Dr. Shin, you want to say something?
I think it's a nice and elegant technique. So I had some experience in the past trying to use two choppers to chop the nucleus. What I had is always you have to conquer the rotational movement, because as far as these two instruments are not going directly to each other, there is a rotational movement. And
yes,
my question to you: how do you counteract this? Any tips on how to avoid this rotational movement?
Actually, two things are happening with a hard cataract. One is the, I mean to say, when I'm using these two instruments against each other, there's a little bit of torsion, as you have nicely explained, that I'm sensing that kind of torsion. But at the end of that, if I'm little jerky, I may end up producing a complication. So as I'm crossing my equator, I'm little slowing down, so that as I'm approaching the Chang chopper, I'm little slowing down. And secondly, it does happen that in the course of time, the entire endonucleus lifts up in the capsular bag. So that also give me a little bit of what you can say, an ability to get away with that amount of torsion.
Dr. Millens?
So I have a couple of, first of all, congratulations. I think that's a great technique. What is the actual dimension of the chopper? How tall is it?
It's almost 1.6 millimeter.
1.6 millimeter. It
Yeah.
has a curve on it, so
Yeah.
that'll adjust for a little. So I saw from your videos the Rexus sizes you were using were on the larger side.
Yes,
What's the smallest Rexus you could use this with, you think?
To make the maneuver easy, because we are dealing with hard cataract, so naturally as a Indian person who has been trained for SICS, that is a priority. Like if I end up producing a complication, I should be able to convert. And the best thing that can help me is having a large size Rexus.
Okay.
Like I err on doing a little larger Rexus rather than a classical 5.5 millimeter Rexus and then having a complication. So
the next question comes, do you think you could use this chopper with a 5 millimeter Rexus?
It will require a little bit of expertise, and moreover, one of the steps which I have not demonstrated is I am making it compulsorily essential to aspirate a little bit of cortex and epinucleus over the surface of the, as soon as I do my hydrodissection, I make it sure that I aspirate a little bit of chunk of the tissue so that I get a little purchase into the endonucleus with my Chang chopper. So that creates a little bit of space.
Is your chopper sharp enough to go through the nucleus vertically?
It is very sharp, sir. It's very
So
sharp.
it'll go through vertically, straight through, anywhere?
And yeah, but my
Or
direction
do you
of
have
impact.
to start it from the edge
Yeah,
of the
direction of the
nucleus?
impact is not directed posteriorly, it is obliquely. So I have never had in all these, say for example, 800-900 surgeries, I have never ended up producing a PCR. Nonetheless, I have hooked the intercapsular margin and produced a zonular dialysis. That is true, as can happen with any horizontal chopping surgeon. But producing a catastrophe like PCR, I have never encountered.
And have you tried the MyLoop at all?
MyLoop, I don't have an
It's
access
a similar
to.
principle, but done in a different way.
Yes.
Thank you.
Thank you,
Thank you,
sir.
So after that interesting video, we have now another interesting video by Dr. Saurabh Patwardhan, and this is, he will be doing SFIOL with the Yamane technique and a pupilloplasty as well, and we'll request Dr. Yamane to comment on this after the case is over.
Hello. In this video, I am demonstrating a case of scleral fixated IOL with Yamane technique and pupilloplasty. So this was a 50-year-old male who presented to me with a history of 3 times operated for post-traumatic retinal detachment. Patient had surgical aphakia with severe traumatic mydriasis causing lot of glares. After oil removal, the retina was attached, but patient had poor vision because of aphakia. So I decided to go ahead with scleral fixation of IOL using Yamane's technique. I placed a pars plana infusion cannula because this was a vitrectomized eye. I used a 26 gauge needle at 2 millimeters from the limbus. I tried to make an intrascleral pass of around 2 millimeters and then pass the 26 gauge needle into the vitreous cavity just behind the iris. Once the entry was done, I kept the 26 gauge needle as it is, and then I started injecting a hydrophobic IOL with PVDF haptic. I made sure that the leading haptic went into the bore of the 26 gauge needle. I threaded it further using 25 gauge end grasping forceps. Once it went inside the 26 gauge needle, I carefully placed the 26 gauge needle tangentially on the scleral surface. Then I passed another needle, 26 gauge needle, 2 millimeters from the limbus. Tried to push the needle at least for 2 millimeters into the sclera and then pierce the sclera exactly 180 degrees above opposite to the place where the other side needle was pierced. Then using the 25 gauge end grasping forceps, again I pushed these PVDF haptics into the bore of the needle. As these are PVDF haptics and not PMMA, so there is no chance of breaking of these haptics. Once they are threaded, both the needles were withdrawn, trying to withdraw it simultaneously. So as you can see, inferiorly the haptic has come out. Superiorly, I again push the haptic using the forceps, so it comes out of the sclera. So it is a transconjunctival scleral tunnel through which the haptic has come out. Following this, I used a thermal cautery and I enlarged this tip of the PVDF haptic so that the haptics will get stuck in the intrascleral tunnel. It was done on both sides, and then I gradually pushed the haptics into the intrascleral passage or the tunnel which was there, or the needle track, and they went nicely in that needle track, and you can see here that the conjunctiva will cover these haptics completely. The IOL is very nicely centered and stable in the eye. Now I decided to do pupilloplasty. This was quite shrunken iris, so using the 25 gauge end grasping forceps, I pulled it, stretched the pupil, stretched the iris so that I could grab one part of the iris near the pupillary margin, take a bite of needle is attached to the 90 proline suture. Then it was passed to other end of the iris. As you can see here, the superior part of the iris was absent, most likely because of the trauma. This was a repaired corneous perforation, following which there was retinal detachment, which was operated, and then oil removal was done. I used the single pass 4-throw method of suturing to do the pupilloplasty on both superior and inferior side. Thus I could achieve relatively good size pupil, and this was patient's post-operative photo. Patient had 6/24 unaided vision. Thank you.
Thanks, Dr. Saurabh, for that nice video. And now we'll request Dr. Yamani to comment on this video if you would have any comments.
Yeah, nice video. Thank you for using my technique. And first question, which IOL do you use?
I use Medenium IOL, which has PVDF haptics. Actually, this was my first case. When I searched through, I think PMMA haptics don't bend well, so I looked for a PVDF, and in India I could find that.
Can't you insert the haptic into the 27 gauge needle?
I tried with 30 gauge, but it was not going. It was slightly thicker, as you could see that. I could thread it well in 26 gauge without much of a space in between, so that's why I used 26. Unfortunately, I didn't have access to 27 gauge thin wall needle, but I think this did the job well.
Okay. And you made a corneal incision at 9 o'clock position,
Yes.
but I recommend you to shift to 10 o'clock. It's easier to insert the haptic into the needle.
Okay. Thank you, sir. Thank you. And there was a lot of scarring, conjunctival scarring. So I think thanks to your technique that we could do a minimally invasive procedure in this particular case. Otherwise, it was really hard for the patients to get.
What would you say anything about the use of the thermal cautery, because it looked scary to me with the thermal cautery, like a low heat cautery which can flatten it nicely. I mean, have you tried using one of these other cauteries?
Yes, actually I had that cautery, but it was not.
It was
working.
not available at that time.
It was not working at that time.
I would be scared. I was only wondering that if it just kind of melts it so fast that.
So I have to be very careful. So it was an old method, like my father was using. So I'll
course,
let
we,
it cool down little bit and then
you
did
use it.
Yes,
Wonderful.
right.
Thank you. And we'll go on to the next case. And before we go on to the next case, I would like to remind that at the end of this session, which is just, we have 3 more videos left, 3-4 videos left, we will take an audience vote for the most challenging or the most, the best video out of these. And the judges will be giving us the 2 winners for the best teaching video and the best new technique. So we'll go on, and Ashwin is going to take over for the next case.
Dr. Soumya Yadav? Yes. While she comes on, we will play her video.
Cannular-associated ocular injury is a commonly recognized complication which can lead to a spectrum of iatrogenic intraocular injuries, including both anterior and posterior segment. In this video, we will describe your case where a viscoelastic cannula acted both as a
Sir, the
wrecker
video is
and
not
savior
playing.
during the cataract surgery. Author has no financial interest.
So the video is not playing.
A 62-year-old male was planned for fecal multiplication surgery with toric island. Cannula-associated ocular injury is a commonly recognized complication. After a quick assessment, cannula-associated occlugenic intraocular injury
Let's go, from the directly from the folder.
Cannula-associated ocular injury is a commonly recognized complication which can lead to a spectrum of iatrogenic intraocular injuries, including both anterior and posterior segment. In this video, we will describe your case where a viscoelastic cannula acted both as a wrecker and savior during the cataract surgery. Author has no financial interest. A 62-year-old male was planned for fecal multiplication surgery with toric island implantation under topical anesthesia. After the initial marking of access of toric island, 2 sideward entries were made. A cohesive viscoelastic was injected into the anterior chamber using a 27-gauge cannula. As it can be seen, during injection, viscoelastic cannula dislodged suddenly and directly hit the lens, causing a 360-degree zonal dehiscence and its dislocation. After a quick assessment, we realized that the cannula was acting as an anchor, passing through full thickness of lens, thus preventing its posterior dislocation into the vitreous. Without causing any further manipulation of the cannula, we converted the fecal multiplication into an intracapsular cataract surgery via a superior approach. Till the time we delivered the lens, the viscoelastic cannula was held in place by the assistant. And was used as an anchor at the time of the delivery. After carefully removing any vitreous from the wound was sutured. Intracannular pilocarpine was injected. And a limited anterior vitrectomy was performed. Sutures were buried. Wound was hydrated and the patient was left aphakic. A second stage anterior chamber island implantation was done and the patient achieved a best corrected visual acuity of 6 by 9 at 1 month post-op. Such drastic complications during routine cataract surgeries can easily be prevented by taking simple precautions. Following are the take-home message from this case. Prior to any intraocular syringe should always be checked by surgeons themselves. A sudden disappearance of airspace can lead to a sudden surge of pressure during injection and damage to the eye. So any airspace from the syringe or the cannula should be removed. Prior to intraocular injection, a squirt test should be performed to ensure the tightness of the cannula. The hub of the needle should always be supported while injecting, and the cannula should be directed away from the posterior segment. Thank you.
Dr. Grover, would you have a few comments about this case and how you would manage it, or anything different that you would do? Just leave it on mic.
Thank you, Dr. Soumya, for having driven home the carry-home message very well, that you need to be doubly sure of your tightening of the cannula before you inject either air or an OVD. That needs emphasis, re-emphasis, because we've all at least caused a hyphema, if not dislocation with that when the cannula comes off. I was just wondering why you didn't choose to use a vitrector, why a sponge vitrectomy? The other thing that I wanted to ask you about was delivering with a vectus is fine, but would you not try and coat the cornea with a good viscoelastic before you do that, so that you have a better protection of the endothelium, or maybe use another instrument in front to keep the nucleus safely away from endothelium when you deliver it?
Yes, thank you, sir. Actually, we did use a viscodispersive viscoelastic before delivering it, and the cannula was actually acting, the assistant was holding the cannula, and she just directed it towards the wound while delivering. So there was not actually much of a rubbing of the endothelium delivering.
Okay. Anybody else wants to come in?
Yeah, nicely done. I would like the opinion, starting with Dr. Boris. What is your opinion today on anterior chamber IOLs?
You know, my opinion, I personally don't use them, first of all, and but I remove them quite frequently during endothelial keratoplasty procedures. So I do believe that the latest publication on that was from a paper from the American Academy of Ophthalmology that was comparing different types of IOLs, iris suture fixation, scleral fixation, and anterior chamber IOL. And I think that the conclusion was that they all work more or less well. And there is a general recommendation, if you consider using anterior chamber IOL, think about life expectancy of the patient. It's definitely not the case for the younger patient. However, if you have a kind of old patient with a lot of comorbidities and you think that your scleral fixation will take too long, and so it might be a good idea to use something very simple, very quick. And so I'm not against that type of lenses, given in mind that comment about the life expectancy and the...
Any comments from the panel on primary versus a secondary quadriflex IOL implantation? This was a secondary done at a later stage. Couldn't that be done at the same time if you get a good meiosis?
So, actually, we were not really sure what's the extent of the injuries, since it was like a quite extensive, it caused the 360 degrees zonodescence. That's why we waited. We planned a second stage so that we could do a thorough fundus evaluation. That was it.
Okay.
Yeah.
Can I just ask whether your syringe that was used, was it a lower lock syringe?
Yeah, ma'am. It was a Helon syringe, and probably the most likely explanation was like it was not correctly placed by the assistant, and I obviously checked it quite nicely, so that was the explanation. Could have like just short.
Thanks. We'll quickly go on. We have last two videos now. Dr. Kumar, speaking on small is tough, and let's see.
Small eyes can be classified according to anterior chamber depth and axial length. This video will demonstrate the challenges found in two cases: extremely short axial length and a small ACD, namely the nanophthalmos. A unique complex case, a software engineer by profession with high hyperopia was referred for refractive correction. On examination, her best corrected visual acuity was 20 by 40 part in both eyes with a correction of plus 12 diopters. On slit lamp examination, she had a normal sized cornea and a very shallow anterior chamber, and gonioscopy showed occludable angles with a normal IOP. She underwent a prophylactic YAG-PI in both eyes. Her dilated fundus examination revealed heaped up optic nerve head and retinal vessel tortuosity with an attached retina in both eyes. OCT macula was normal in both eyes. A detailed imaging was performed on tomography, optical biometry, and a corneal wavefront and an ocular wavefront analysis was done. What the test revealed was indeed unique and surprising. Her white-to-white diameter was 10.7, her ACD of 2.68, and her lens thickness of 4.27 in both eyes. Her axial length in OD was 14.85 and OS 14.89. Her average keratometry in both eyes was 56, a very steep cornea. IOL power calculation by different formula varied from 49 diopters to 65 diopters. B-scan showed a thick chorioscleral complex, 2.06 mm in the right eye and 2.23 mm in the left eye. On conclusion, it was an extremely short eye, a very steep cornea, a very shallow anterior chamber, and a normal lens thickness, almost 1/4 of the whole eye. A thick chorioscleral complex, so a nan-ophthalmic eye, or shall I say a PIC ophthalmic eye. Set the wheels rolling, made many calls, wrote emails, asked, discussed, thought, and reviewed literature. The patient was planned for clear lens extraction. Decided to go ahead with a customized hydrophilic foldable IOL of 65 diopters to be injected through a small incision of 3.4 millimeters. The challenges faced is IOL power calculation, manufacturing a customized high diopter power IOL, and injecting the same safely through a small incision. Well aware of the various complications known in nan-ophthalmic eyes, adequate precautions were taken before, during, and after surgery. Patient taken up for femto, rhexis, and a 4-quadrant division of lens performed. A 0.75 millimeter side port incision made and a gentle release of the aqueous, replaced by an OVD. Using a microrhexis forceps, the CCC was rasped out. Bimanual IA used for aspirating the lens material. Globe not allowed to collapse because of the use of the OVD. Main incision of 3.4 millimeter made. 65 diopter, highest ever IOL manufactured, was loaded, placed in the cartridge, and then injected. Loaded the hydrophilic IOL. Significant amount of pressure needed to push the 1.9 millimeter thick IOL through a 3.4 millimeter cartridge. Precaution taken to not let the globe collapse. IOL placed in the bag and the trailing haptic dialed into the bag. Suture placed, bimanual IA done for OVD removal. Air placed post-operatively, overwhelmed to see the first day post-operative visual acuity of 20 by 60 and a refractive error of -1.5 spherical with a -1.75 cylinder at 20. On conclusion, a comprehensive approach for such challenging cases like nan-ophthalmos or micro-ophthalmos can have good visual outcomes. Thank you.
Thank you. So, Dr. Chi, would you like to comment on this?
was a beautiful video. You really thought through the problem and you planned for this patient. But you didn't tell us what type of anesthesia this patient was under.
Topical. She's 21-year-old.
Okay, because you know if the patient starts to squeeze or struggle,
Yeah.
you have an
But
expulsive
she's very, very
hemorrhage.
smart. She's an engineer. I wonder how she studied with a +12. She's very cooperative. And you'll be shocked if I tell you the end. At the end of now 3 months, she had the 1.52 became -3 with a -2 SIL. I went ahead and did a surface treatment because her keratometry was 57. And now she's a -0.75, a 618 unaided. She's extremely happy.
Yeah, I was going to ask you whether you targeted plano or what you were targeting.
I don't know what to target because there is no formula which accepts. We try any formula and you try to put in a 57 diopter, it just does not accept a calculation.
Yeah, so my question is, did you do a UBM to
Yes,
have a
we
look,
did a
see
UBM,
whether there's an
yeah.
effusion? Because very often, you know, these really small
Yes.
eyes is hard to predict because you can't even predict the final effective lens position.
So we did a UBM and that's how we got all the sizes. Plus we looked for that and we looked at the scleral, the thickness, choroidal thickness. So we did all of that.
Yeah, because I've had a patient
Yes.
that, you know, was exactly the same,
Yeah,
14.5, and at 3 months she suddenly became myopic. And even though we didn't see an effusion, we put her on atropine and everything went back.
So I maintained atropine for her for a long time. I didn't stop atropine.
So you
For
put it right
almost
from the
2
outstart.
Yeah, 2.5 months, 3 months she was on atropine.
Come on, just a quick thing on the anesthesia.
Yeah.
It's great to do topicals and everything, and it's not really a matter of getting away with it in these kind of patients, but doing these patients under a general anesthetic is actually gives you a huge advantage, and the simple reason for that is your anesthetist can adjust the choroidal gas to adjust the choroidal blood flow, the PCO2 to adjust the choroidal blood flow, and it gives you amazing control over these patients in terms of the AC shallowing and all the other issues that we get with these kind of patients. So, I mean, it's something I would suggest.
You're right,
consider.
absolutely, Milind. There's no doubt about what you said. But my only fear was because I did a femto. So I would have to shift the patient from that table to this table. That was the only thing for this. And she was very, very cooperative. But you're right. I mean, there
I'm
is
sure
no doubt.
you do a manual Rexus better than your femto.
Thank you, Dr. Kumar.
Thank you.
I want to comment what
Sir.
was the it was very challenging case. What was the post-operative anterior chamber depth? Because something you told
Yeah, pre-op.
pre-op you told it was less.
Yes.
And post-operative what was the this and what was the intraocular pressure in the long term or short term whatever.
Till
you
now,
have.
it's about 4-5 months up. The pressure is normal. As far as the post-op ACD, I've not measured, but the thickness of the lens is 1.9. So we have to subtract 4.7 was the pre-op lens thickness. The ACD was 2.68, and now I put in a 1.9 thick IOL. So that would be the post-op anterior chamber depth.
Thank you, Dr.
Thank
Kumar.
you.
Thank you, panel. Can we have Dr. Shilpi? Thank you. This is probably the last video, so audience get ready to vote after this and help us.
Cataract surgery done at age 10 years. On examination, her best corrected vision was 1/60. Slit lamp examination revealed coloboma of iris with residual after cataract Curie-Somerins ring with tambling subluxated IOL. The fundus evaluation showed rigid single-piece IOL in vitreous cavity with type 4 retinochoroidal coloboma involving macula. We planned for membranectomy, vitrectomy, plus IOL explant with SF IOL, very well being aware of the risks involved in a one-eyed patient with congenital anomalies. After informed consent, patient was taken for surgery under local anesthesia. 23 gauge ports were made at 8, 10 and 2 o'clock positions. 2 limbal side ports were made at 10 and 2 o'clock position. Conjunctival peritomy done at 10 and 4 o'clock position. Partial thickness scleral flaps created in the same meridian. 23 gauge trocar was piece rigid IOL. The haptic was externalized by handshake technique using two scleral fixation forceps. The same was repeated with the second haptic. After externalizing the haptic, they were buried into the tongue. For additional security, we anchored the haptics in the bed of the scleral pocket with 8-0 Vicryl suture. Superficial scleral flaps were sutured with 8-0 Vicryl. At this stage, we also decided to repair the coloboma. The partial thickness scleral flap was created at 6 o'clock position and with 8-0 Prolene suture, coloboma was repaired to the best possible extent. At 1 month post-op, the patient had best corrected visual acuity of 3 by 60 with well-centered IOL and a decent pupil. So, in such a congenitally weak eye, you can be a daredevil, but a minimalistic, less morbid procedure is to be adopted.
Fantastic. Dr. Shin, would you attempt to do something different in this case using your technique? And Dr. Milan, if you can have your thoughts as well.
Yes, and I never fix a one-piece PMMA lens because the diameter is short, small. So, but in this case, maybe the cornea diameter is shorter than the normal eye.
Yes, sir.
What, did you measure the white to white?
No, sir.
It looks 11 or 10.
Dr. Jagat, would you like to want to comment on this? It's good. Anybody else? Dr. Milan, what do you?
These are always challenging cases, and what works in one case doesn't necessarily work in your next case. So it's very well done. The only thing I was wondering was whether you explored the option of dissecting the Morgagnian remnants, or not the Morgagnian, the residual remnants away from within the capsule, and that might give you some fixation support, at least in one area possibly, for a lens to sit in this, for that lens to sit in the sulcus. I'm not sure whether it would work or not, but it's just a thought as to that's the other option. Instead of clearing the whole thing, if you just open up the capsule and see if you can take away, dissect out the residual fragments from within that and leave the zonule and the capsule intact to see if you can get enough support there. But great way of doing it, and it's worked. Thank you. Congratulations.
Thank you, sir.
Thanks. And we skipped one video in the middle, so last but not the least, an excellent video again. Dr. Meenu Mathin, and I'll start it off right.
Encountering hypermature Morgagnian cataracts is not uncommon in our surgical practice. They pose significant challenges during surgery because they can present with small pupils, calcification of anterior capsule, loose zonules and weak posterior capsule, and the lack of cortical cushion can make phacoemulsification very difficult. They can also have corneal edema and leaked cortex in the anterior chamber when they reach the phacolytic glaucoma stage. This video deals with the management of 3 different cases of Morgagnian cataracts, presenting with a combination of multiple surgical challenges. In the first Morgagnian case, the plan is to perform phacoemulsification. The anterior capsule is stained with trypan blue and a capsulorhexis is initiated. The leaking liquid cortex is aspirated by the same bent 26 gauge needle. Once the capsular bag is partially emptied, the hard nucleus becomes visible. The capsular bag is inflated with viscoelastics and the CCC is continued with the capsulorhexis forceps. The tearing margin is regrasped many times and the chamber is retained well formed with OVD to avoid peripheral extension of the CCC. Now to initiate phaco, we try to stabilize the nucleus in the bag. as the bag has no cortex and the nucleus is much smaller, the nucleus keeps spinning in the bag with the fluid current, and the posterior capsule is very tremulous. The nucleus now is moved to one side in the bag, and the bag is filled with high molecular weight OVD. A single piece hydrophobic acrylic IOL is injected into the capsular bag, and the nucleus is stabilized in the bag over the IOL. A direct chopping technique is employed using a long sharp tip chopper to split the nucleus. The IOL protects the posterior capsule from accidental touch by the phaco needle. The anterior chamber is filled with dispersive OVD to protect the endothelium. Care is taken to avoid the phaco tip touching the surface of the IOL. As the nucleus is hard and leathery, complete splitting of the nucleus has to be ensured for comfortable emulsification of the fragments. As there is no more cortex to be aspirated, the wounds are hydrated after aspirating the OVD, and the IOL is well centered in the capsular bag. In the second Morgantian cataract case, it has reached the phacolytic glaucoma stage. Here, the leaked liquid cortex in the anterior chamber blocking the view is initially washed out with BSS. The anterior capsule is stained with trypan blue. The corneal epithelial edema still makes the view hazy, but with few strokes of a wet cotton spud rolled over the cornea with moderate pressure, the cornea clears instantaneously. A temporal corneoscleral tunnel is fashioned. Now the thick calcific plaque in the center of the anterior capsule is seen. Capsular rhexis is initiated away from the calcific plaque. As the rhexis proceeds, care is taken to avoid running into the multiple other calcifications present on the capsule. The capsular rhexis forceps, along with multiple reinjections of OVD, helps in successful completion of the rhexis. As the nucleus is very small, it can be delivered out by visco expression. There is no more cortex to be aspirated, and a single piece hydrophobic acrylic IOL is implanted into the capsular bag. The residual OVD is aspirated, and the sutureless corneoscleral incision is closed. In the third case, the capsular bag is seen empty. The anterior capsule is intact, and a complete CCC is fashioned. When OVD is injected, the large tear in the posterior capsule becomes clear. This was a spontaneous rupture through which the small nucleus has dropped into the vitreous. 3-port pars plana vitrectomy is performed to release all vitreous adhesions around the nucleus, and it is lifted up. Through the open posterior capsule and the anterior capsular rhexis, the nucleus is positioned in the anterior chamber. A multi-piece hydrophobic acrylic IOL is implanted into the ciliaris arcus under the nucleus and above the anterior capsule. Lot of dispersive OVD is injected under the corneal endothelium. With the sharp-tipped phacochopper, direct chopping is performed. The IOL acts as a scaffold to cover the capsular rhexis opening while the nucleus is emulsified, preventing loss of nucleus bits into the vitreous. Slow motion phaco is employed, and care is taken to avoid nucleus fragments from touching the endothelium. After the nucleus is completely emulsified, the vitrectomy is also completed, and the IOL is seen well centered. Thus, excellent surgical outcomes can be achieved in such extreme situations by adopting the appropriate modification in surgical technique for each specific situation during instrumental phaco and manual SICS. Thank you.
Dr. Rohit Prakash, would you like to comment on this?
I think this IOL scaffold to prevent PCR is an excellent technique, and this we published in JCRS also. You know, this mobile nucleus, there's a small trick which we are presenting in, which we have sent for, is that you take equatorial support in the first case. You nudge the nucleus towards the opposite equator, and with the equatorial support you'll be able to immobilize the nucleus, and then you can proceed with the direct chop. This is a very small trick, but you try it and you will find, and it works well.
Dr. Grover sir, would you like to add anything to that?
Negotiating those with calcification can be very challenging. Sometimes you get away with it, sometimes you don't. So that was very well done.
I think Dr. Deepak Magur has already shown an excellent video for that.
So, and even the third case was quite innovative, where you brought it up through the broken posterior capsule and then, as scaffold, and then, anyway, thank you so much for all those videos. First of all, I would like to thank all the presenters, but now we'll quickly do a round of the vote, and I'll request the audience to please help us with that. And We will start from the first one, and the judges to please watch because you have to decide about the 2 other awards. So going ahead with the first video, how many people would like to vote for this video to be amongst the most challenging cases? We'll have raise of hands so that, and Ashwin is going to keep count. So, okay, we have one there. Absolutely allowed to vote, absolutely. So we are going to subtract 1 from all the votes, you know. And then we have the second video presented about the iris hook with the Yamane technique for the subluxated oil by Dr. Amit Mishra. We have, you're keeping count. Okay, so then we have going on, we have the next one for the OCT guided posterior polar cataract surgery with intraoperative OCT by Dr. Amar Pujari. So how many takers for that for the best video, most challenging video? We have Dr. Ashish Lal, who demonstrated PCR management using fluid dynamics with viscodispersive and bimanual aspiration cannula. So how many takers for that? We have a few, yes. And Dr. Deepak Megur, mysteries of traumatic cataract for, I think, let's see show of hands. Anybody? Okay. So I guess, all right. Dr. Manish Mahindra, iridodialysis repair and modified techniques. How many takers for this video, which was showing iridodialysis repair? Can we have raise of hands? I think people are, yeah, most people are not voting. I think they're waiting for some video to come up. Is it? Okay. Then we have Dr. Meenu Mathin, who just showed his video on the Morganian challenge. And let's see a raise of show of hands for I think because of this poor response, should we leave all the 3 prizes to the judges? Let's because should we continue? Okay. All right. So then we have iris fixation of subluxated IOL back complex, Dr. Neeraj Agarwal, and let's see raise of hands for how many takers for this. When will the surprise come? Dr. RP Singh, dropped IOL bag intact, and yes, so we have a better response here. All right. Going on, Dr. Sohail Irfan Mohammad Khan, cataracts and novel pre-chopper. Wow, so I think till now, so far, this probably is taking the cake. And then we have Dr. Saurabh Patwardhan, SFIOL. So we have quite a few followers sitting right at the back, right? So it's going to be between these 2, I think. Dr. Soumya Yadav, viscoelastic can make a big, I think the title is here wrong, but it was about the viscoelastic cannula causing injuries. How many people? No. And then we have Dr. Kumar Doctor for small is tough with that challenging case. All right, so that boils down to between Dr. RP Singh and Dr. Sohail Khan. Can we call both of them here and then take a final vote? Because was it almost similar, or did you think?
I think it was almost similar.
It was almost similar? Can we have both of you here on stage, please? Dr. RP Singh and Dr. Sohail. So, Saurabh ka bhi tha usme? Only 2 of them carried the maximum votes, right? Meantime, I would suggest judges can please try to decide amongst you. You've already decided? Wonderful. So the 3 categories, one was the most challenging video, which is coming up now, and then we have the best teaching video and the best new technique.
New technique and teaching.
So best teaching video and the best new technique.
And now it's going to be based on volume.
So now I think we'll do a voice vote, because now we've had enough show of hands, and let's have a voice vote. Get your throats ready. And how many people? Let's hear it for Dr. RP Singh. Yes. Let's hear it for Dr. Sohail. Yes. Okay. I guess that makes it Dr. Sohail. So congratulations, Dr. Sohail, for the audience vote. And well done, RP. You did well too. And we'll request Dr. Boris and we'll request all our foreign faculty to please come in and give away this award. Can you all come together and give it to Sohail? Invited guest faculty from abroad. We'll have Dr. Yamane, Dr. Milind, and Dr. Chi. It's right here. I'll now request the judges to announce the other two awards, and then, we've had a session run a little late. So who's going to take the responsibility to announce? Dr. Rohit or?
I think there have been 3 who have been outstanding. Yeah, Doctor. Yeah, absolutely.
Okay.
Dr.
So-
Sohail, Dr. Matthew, and Kumar Doctor.
Okay.
Yeah.
So, Matthew, you mean Meenu Mathan?
Yeah.
All right. So, I think we have between Dr. Sohail, Dr. Meenu Mathan, and Dr. Kumar. I think since the grand prize has already gone to Dr. Sohail, we have these 2 which are the judges' choice. Do you think?
I think judges have unanimously decided Dr. Sohail #1.
Right.
Best possible by everybody.
I understand. Yes, absolutely. So should
Without
we
conversing
give the-
and without.
I think everybody wrote this.
Everybody is of the opinion on the dais that Sohail is the best.
Right.
And closely behind is Dr. Meenu Mathan and Dr. Kumar. They are almost equal from our side.
So how do you want us to do it? Should we give one of the new technique to Dr. Sohail and we get one more trophy for this for both of them? All right. So I guess what we'll do is we have the best new technique go again to Dr. Sohail, and the second prize divided between Dr. Kumar Doctor and Dr. Meenu Mathan, so that we'll have another trophy made for. We'll make one more trophy of. So it's a joint. So we'll request Dr. Sohail to come up, and now we'll request
6 months each for this trophy.
Oh, it dropped.
To the best one.
You are hidden. You need to get to the front.
You should be in the front. Please come.